Hello, we're going to look at now diseases of the bones. So we're going to concentrate on this part of our initial chart, and you can see that most of the categories fall into the infectious conditions such as osteomyelitis, metabolic disorders, of which there are four main ones that we'll discuss, and then neoplasms. Let's start off by looking at infections or infectious disorders, and this is called osteomyelitis. Most of the time it is caused by bacterial organisms, and there are three main routes of infection. One is directly, for example, if the patient has an open fracture, the bone is actually exposed to the external environment. Of course, there can be hematogenous spread if there's bacteria or organisms in the bloodstream, and also contiguous spread from adjacent organs. And sometimes we see this in middle ear infections, where the patients can end up with mastoiditis. Now, epidemiology is very important, just as I outlined it for musculoskeletal system in general. In children versus adults, not only are the bugs different, also the distribution or the actual bones that are affected are different. So I will leave you to read this up, get this information from your textbooks and your lecture notes. Most of the time, the organisms are bacterial, and this would include organisms that you're very familiar with, such as Staphylococcus aureus, E. coli, tuberculosis as well, TB, can also give rise to osteomyelitis, and many, many other organisms. So aside from the usual clinical presentation of pain, swelling, fever, there can sometimes be complications of osteomyelitis. One of them is the formation of sinuses from the skin all the way down to the periosteum. So this happens when there is infection in the bone and it actually breaks through the periosteum out into the surrounding soft tissue and then thereafter into the skin surface. And this is what happens sometimes in chronic osteomyelitis, can be quite difficult to treat. So acute osteomyelitis, if not treated well or if the infection is not cleared, can progress to chronic osteomyelitis. And often here we will see a piece of dead bone actually within and surrounded by living bone. This dead bone is called the sequestrum. This significantly weakens the structural integrity of the bone and can sometimes predispose the patient to pathological fracture. Now, in addition, in chronic osteomyelitis, there can also be deformity due to weakening of the bone, and very rarely there can be malignant change. Interestingly, the malignant change can occur either in the bone, giving rise to osteosarcoma, the commonest bony malignancy, or in the skin if there is a discharging sinus and lots of inflammation. Patient can actually get or develop squamous cell carcinoma. And because of the chronic state of inflammation, ongoing inflammation, the patients may also suffer from secondary amyloidosis. Now, the second category is metabolic diseases, and there are four main conditions that will be mentioned here. The first is osteoporosis. This is an extremely common condition, and I'm sure you would have heard of it. This is defined as a decrease in bone mass. Some possible causes include primary causes, which include the postmenopausal state, relative estrogen depletion, as well as elderly age. And secondary causes would include endocrine causes, for example, in patients with Cushing syndrome, where there's increased endogenous steroids. Steroids can give rise to decreased bone mass in terms of decreased bone formation and increased resorption. And malnutrition, of course, can also give rise to osteoporosis because there are lots of building blocks that are required to make up the structure of the bone. And certain medications or drugs, steroids, these are essentially very similar to steroids that are produced by the adrenal cortex, it's just that they are exogenous. There's also prolonged immobility, which can give rise to osteoporosis. And clinically, they are usually not really symptomatic until the patient experiences a pathological fracture. For example, typically in the neck of the femur or in the wrist when the patient falls and lands on the outstretched hand, outstretched arm. And then in the X-ray, what we would see would be thinning of the bony cortex, as well as decreased in the bony trabeculae. So this is an example. It's not a typical X-ray that you would see, but this is just an X-ray of a vertebral body, and on the left you can see the normal cortex and the trabeculae, the internal structure of the bone, whereas on the right this is osteoporotic. The cortex is thinned and that you can hardly see any of the bony trabeculae. Now the next condition is osteomalacia. Osteomalacia is defined as decreased bone mineralization. So this is not the same as osteoporosis. In osteoporosis, the ratio of the mineral content to the osteoid is the same, but in osteomalacia there is actually decreased mineral content relative to osteoid. So decreased mineralization of osteoid. What do I mean when I say mineral content? This generally would include the calcium and the phosphate content in the bone. And this is often the result of abnormal vitamin D metabolism or vitamin D deficiency. Vitamin D deficiency can be a result of dietary deficiency or decreased sun exposure. Also not included here, malabsorption, if there are gut disorders, can also give rise to deficiency. So in terms of metabolism, we are thinking about patients with chronic renal disease because the enzyme that is required to produce the final active product of vitamin D is in the kidney. So clinically, in patients with osteomalacia, the bones will be weaker, and this may give rise to microfractures. Osteomalacia that occurs in children before the closure of the epiphysis, this is known as rickets. And in rickets, there is often deformity or bowing of the bones because the bones become soft. So then they tend to bend under the weight of the individual, and this gives rise to a short stature and bowing deformity of the bones. So hyperparathyroidism is the other condition that we're going to talk about. And this is characterized by excessive bone resorption. And what does the actual resorption? These are osteoclastic giant cells within the bone. So osteoclastic, excessive action of osteoclastic giant cells, and sometimes we can even see accumulation or aggregation of these giant cells, which I will talk about later. It is often due to raised serum parathyroid hormone levels, and this can be due to tumors in the parathyroid gland, for example, a parathyroid adenoma, which can produce excessive PTH. Also can be due to chronic renal failure. So there is a resulting raise in the serum calcium levels because of resorption, and in the bone there is an interesting tumor, or sort of like a pseudo-tumor that is formed, which we call brown tumor, sometimes brown tumor of hyperparathyroidism. On histology, what we see are aggregates of osteoclasts. These are giant cells. These are the cells that actually eat up and do the job of resorption of the bone. You can see here, here, here. So there are many multinucleated giant cells, which are osteoclastic giant cells in the brown tumors. And this can, of course, give rise to pathological fracture. The last metabolic disease that we're going to look at is Paget's disease. So this is not the same as memory Paget's disease, totally different. This one affects the bones. And this is an interesting condition because there are two things going on. There is both excessive bone resorption by osteoclasts as well as uncoordinated new bone formation or action of the osteoblastic cells. So there are two main types of cells. We have the osteoblasts, which are responsible usually for laying down the osteoid. And then we have the osteoclasts, which are responsible for resorption of bone. And we have abnormal activity of both of these cell types. So the cause is not well elucidated. It's thought to be possibly viral in nature. In terms of distribution, Paget's disease tends to favor the axial skeleton. So the cranium or the skull, the spine are affected, and this more so than long bones, although of course long bones can also be affected. Clinically, the patients may experience severe secondary osteoarthritis because of deformity of the abnormal bones, and there may also be nerve compression, for example, in the skull and in certain orifices or grooves through which the nerves run, and this can give rise to deafness. In addition, the newly formed bones are often hypervascular, and this leads to the formation of arteriovenous shunts, which can eventually lead to increased work required by the heart and therefore heart failure. Another relatively rare complication is malignant transformation. Very rarely, less than 1% of the time, Paget's disease can evolve into osteosarcoma. And actually, there's one more clinical effect here, and that is deformity. This may be quite obvious, particularly in the craniofacial skeleton, because of a prominent frontal bone or forehead. The last category of pathology in the bone that we're going to talk about is neoplasms, and this will be covered in the next mind map.